Well, good morning, everybody. That wasn't very Parkinson's hyperphonic. Good morning, everybody. Thank you. You can't be quite as tired as I am. Okay, we have a great session this morning. We have Lynda Anello with us. She's the community liaison for Vitas Healthcare, and she's going to talk to you about advanced care planning. And please listen carefully because it will make my job easier in the future. No, I'm really looking forward to hearing what this is about. So, Lynda.
Thank you very much, everybody, for choosing to attend this session. I feel it's a very important topic, and hopefully by the end of this presentation, you'll see that it is as well. So we're going to talk about advanced care planning, communicating your decisions for care and your wishes. So this topic a lot of times is misunderstood to be a topic that should only matter in the last months of life, when actually it's really important for any adult 18 and up. So if you're in this audience and you're very young and you think that doesn't apply to you, please pay attention. All right, so we're going to talk about the origin of advanced care, advanced directives. So what does it mean, advanced directives, and where did they come from? We're going to define what advanced care planning means. So there's a difference there between advanced directives, advanced care planning. They're related concepts, but they're not the same. We'll identify the types of advanced directives and their function, and then provide guidance and resources for you to make sure that you're able to get your advanced directives completed. So we're going to start with a little bit of a background on this topic. End-of-life issues regarding patient autonomy, quality of life at the end of life, and withdrawal of life-sustaining treatments. That's what advanced care planning is aimed at. And it started really back in the 60s, but it really picked up in the 80s, and by the 1990, Congress enacted the Patient Self-Determination Act, which gives the patient the right to either refuse or accept certain medical treatments. Then it safeguards the patient's autonomy so that it preserves their self-determination, so that they have a say in how their end-of-life experience goes. And it protects patients against maltreatment being overly aggressive treatment that they don't want, or if they do want treatment, making sure that they get it at the end of life. Fostering communication between patients and their physicians. That was the goal. That is an ongoing, challenge and opportunity, is to foster communication between patients and their physicians, because the patients are often waiting for the physician to bring up the topic. The physician is maybe waiting for the patient to bring up the topic. Some physicians are not very comfortable discussing end-of-life care. They're more comfortable in the fix-it mode. So there's a lot still of work to be done in that arena, and it really takes empowered patients and families who are empowered to ask questions and drive that conversation with their physicians. And this also protects physicians from litigation in end-of-life care planning, because they don't want to be sued by a family for being overly aggressive or not taking aggressive enough measures. So having a patient define what they would want and following the patient's wishes takes away the fear of litigation. All right, so a little bit of background on this. These are 3 famous cases that precipitated this act that Congress implemented. And you can see that these are all very young patients in their 20s. So this is just to show you that advanced care planning is not just for elderly people or very chronically ill people. All of these women were in their 20s. Karen Ann Quillen was 21 in 1975. She had lapsed into a coma and was in a persistent vegetative state, so no brain activity, and on life support. Her parents wanted her taken off of life support. This is what's considered the first right to die case in U.S. legal history. So her parents said, this is not life, this is not quality of life, she would not want to live this way, and we want her taken off of life support. But they couldn't make that decision at this time. They had to end up fighting for her, and eventually she was weaned from the respirator, but they also left her on tube feeding. So in spite of being weaned from the respirator, she lived on tube feeding for 10 more years and eventually died in 1985. Then Nancy Cruzan, she was on life support for 7 years, and there was a contracted fight between her parents and the court system. She was 25 years old and had a wreck, a car accident, and was thrown from the car. In 1987, 4 years after that, her parents decided that she should be removed from the feeding tube. And this ended up going all the way to the Supreme Court. In 1990, they finally allowed her to be removed from the feeding tube, and she died 11 days later. So from 1983 to 1990, she was on life support. Yes. What happened? Oh, thank you. This is not staying in. Let me try screwing that in a little bit. Thank you. All right, so that's going to be on the recording, huh? Okay, so then Terry Chavo, and this was, she was on life support for 15 years, and this time the fight was between her parents and her husband. So in 1990, she was 26 years old, and she collapsed at home. She ended up being on life support in 1998, so 8 years later, her husband finally said, okay, this is enough. She wouldn't want to live this way. Let's go ahead and remove all the artificial feeding. And it was a back and forth battle between the parents and the husband where she was taken on and off of life support. It wasn't until 2005 that they finally were able to take her off of artificial nutrition and hydration and allow her to pass naturally. So those are some famous cases that led to this Patient Self-Determination Act, and you can see they were all very young. And so advanced directives, these are the legal documents that allow patients to formally state their choices regarding what actions should be taken for their health in the case that they are no longer able to make decisions for themselves because of illness or incapacity. So it's important to understand that certain things have to be in place. First of all, the patients are no longer able to speak for themselves. That's a key component. As long as the patient is able to speak for themselves, they're going to be able to continue to make their decisions. But there always or often comes the time in chronic illness especially where that capacity is gone. And so it's really important for people to do this when they're able, early, not wait until late where that opportunity is gone sometimes. And the advanced directives were developed to give a practical process for ensuring that the patient has autonomy, that their voice is heard. And also, you notice the last line there, for their preferences for medical care within the spectrum of reasonable clinical options. To me, the word reasonable should be underlined and highlighted. There are so many clinical options now with advancing technology. They are miraculous in some cases and disastrous in other cases. So it's important to always do a cost to benefit analysis before deciding on any kind of medical treatment. And unfortunately in our society, oftentimes those decisions are made without that weighing of the burdens to the benefits. And sometimes I often hear patients who say, I really regret making that decision. I wasn't well informed when I made that decision, and it's actually decreased my quality of life, added suffering, and trauma and difficult decisions that I have to make now because of that earlier decision. So there's often not enough discussion happening before aggressive treatment options are undertaken. All right, so the two most common types of advance directives are the living will and the durable healthcare power of attorney. The living will, well, we'll get into that in more detail in just a moment. So out of the two, it's great to have both, but if you have nothing else, the durable power of attorney for healthcare is very important because that comes into play anytime you can't make a decision for yourself. It could be temporary. You could be under anesthesia, for example, during a procedure and not be able to make a decision that needs to be made. It's important for the medical personnel to know who is the person that you have designated that you trust, who knows what you would want and can make a decision for you based on your goals, values, and wishes. That's extremely important. So I hope that everybody, if you don't already have that in place after this presentation, take care of getting that done. So these are documents. They're just pieces of paper. So they're by themselves, they have some power, but they're more effective when they're incorporated into a comprehensive planning process that identifies the course that the patient that serves the patient best and outlines specific steps to make that course more likely. So we know that 80% of patients will say, I want to die at home peacefully in my bed, surrounded by loved ones in a natural way. But we also know that the majority of the time that doesn't happen. Probably happens in about 20% of the time. Most of the time, people end up getting rushed to the hospital in an emergency, getting aggressive treatment, and dying after some really aggressive experience. So we want people to know that if you want that peaceful end-of-life experience at home in your bed, surrounded by family, having a natural end-of-life kind of process, that takes planning. It doesn't happen automatically. And if you don't do the planning and the discussions, it's not likely that it's going to go that way for you. All right, so the living will is a document designed to control your health decisions when you're unable to make your own decisions and choices. It only comes into play if you have a terminal illness or you're permanently unconscious. And so you have that document done in advance, but it only becomes activated when you're in that state of terminal illness and permanently unconscious. And it describes what kind of medical treatment you would want in that situation specifically. So it can help your caregiver, your power of attorney, make decisions about things like tube feeding, artificial feeding, ventilators, dialysis, any kind of life support that's going to prolong your life, or in many cases, it's actually prolonging the dying process. And so that's something to really think about. Oftentimes people feel like I have to make this decision because if I don't, I'm giving up and allowing my loved one to die. But really what it often looks like is the person is going to die anyway. You're just prolonging the process and adding suffering to the process. So it's really important to weigh the burdens and the benefits in that particular case for that particular patient. And some patients, having a tube feeding or a ventilator is fine, and they have great quality of life. And other patients, you're just delaying something that's inevitable, and you're decreasing quality of life. So it's really important to look at that on a case-by-case basis. Also part of the living will, you can include do not resuscitate orders, and also, well, actually that's part of the advance directive. So the living will, the do not resuscitate orders, and whether or not you want to donate organs or tissues, that's all part of the advance directives. All right, then the healthcare power of attorney is the document that decides who's going to be the person who's going to have the power to speak up for you if you're unable to speak up for yourself. And that person can make any decisions on your behalf. They'll have access to your clinicians and to your records in order to make informed decisions for you. And if they don't know what your decisions would have been, then they have to do the best that they can to make decisions that they think you would have wanted. And so this is a really big responsibility and can be a really big burden to put on somebody if you haven't had great conversations with them to help them make those decisions. So it's great to appoint the person but you also want to make sure that you've had really great conversations with that person so they can make decisions on your behalf more comfortably and with less burden. This is important that you pick somebody that you can trust. Sometimes people feel obligated to pick their spouse or pick their oldest child or something like that. It's really important that you pick based on a person I can trust, someone who I know is going to have comfort making these decisions, comfort talking to these doctors, asking the right questions, getting the right information. Somebody that is willing to do what you want them to do. If you have specific wishes, that they're willing to honor them. It's also really good to have backup people in line, because what happens if you pick your husband and you're both in the car together and there's an accident? So it's always good to have more than one if you can. And you cannot pick your doctor or your nurse unless that's a close relative of yours. You can't pick somebody on your care team because that would be a conflict of interest. And most states require that this proxy be in writing. We do have in Ohio something called Choices. It's a booklet that includes all of these documents. It's our legal documents for Ohio. These documents are available online and for free. So do not resuscitate orders. So if your heart stops, if you stop breathing, would you want life-sustaining treatment to bring you back, such as a breathing machine? So a do not resuscitate order, these were original. So the CPR, the treatments that brought people back, these were originally developed during times of war for young people, for soldiers. And now they're used across the board. And often you'll see on television, on movies, these heroic CPR where it works almost always. It works and they come back and they're fine. But in the true, in true settings with elderly people, with frail people, with people who have multiple chronic diseases, that isn't really how it goes. There are a lot of things to consider when deciding about DNR. So it doesn't always work. It works best if you're healthy and you don't have illness, and if it can be given within a few minutes of your heart or lungs not working. The longer the time span between those organs quit working and you start the CPR, the longer the time the oxygen has not gone to the brain. And so you can actually bring somebody back with the machines, but their brain has no function, which is the case that we saw in those 3 young ladies earlier. If you have chronic health problems, if you have an illness that can't be treated, if you're older and weak, these are times when CPR does not really work very well. Some potential negative effects. So let me just give you this statistic first of all. If you're in the hospital and you get CPR, you have a 22% chance of it working and leaving the hospital alive, 22%. If you're older, weak, and living in a nursing home, CPR works less than 3% of the time. And some potential negative effects are your lungs are weakened and you would need to be on a breathing machine for the rest of your life. You might need to be cared for in an ICU. You may have brain damage permanently, and also your ribs can crack and your lungs can be punctured from your ribs. So there's a lot of things that we don't see on television that makes CPR look very easy and not detrimental. That makes it kind of difficult for people to make informed decisions. It's important to know what you're facing. All right, with advance directives, it's important that the people that you are choosing as your power of attorney has a copy of your advance directives. It might be great, too, to have your attorney have it. That way, if it gets misplaced, your family knows where they can get their hands on a copy. It's important, too, to talk with not just your power of attorney, but your whole family, because sometimes what we see is a person will designate their power of attorney and not talk to the rest of the family. And then when the power of attorney wants to honor the patient's wishes, the rest of the family who hasn't heard that that's what the patient wishes will fight back, and there will be a lot of crisis within a family where the power of attorney may say, Mom said she doesn't want to be on life support, and then the other siblings are like, I didn't hear mom say that, and I don't think she really would feel that way, and then there's a fight. So it's really important that everybody who has a stake in that decision is informed of your wishes. It's also important to update these documents over time. Things change. When I first got my advanced care plan done, I was 23 years old, and I only had a little toddler. I had to update mine recently because I have 3 adult children now, so I needed them to be included in my plan. So as things change, especially as your illness progresses, you may have different thoughts about what you would want, and you may want to add more detail. So the actual Choices Advanced Care Planning booklet is very simple. It doesn't have a lot of detail about specific decisions that your family might face, but it has areas where you can write those things in. So if you know, based on your illness, what you could potentially be facing in terms of decisions down the road, then you could write in, if this happens, don't do this, or if this happens, do this. You could make it more specific to you. Let's see. And it does, a lot of times people feel that there's a barrier to getting this done because they think it's going to be expensive and they're going to have to hire an attorney. But advance directives are available online. You can print them off for free, and they don't have to have an attorney. They can be notarized, and you can get free notary services at libraries or banks out in the community, or you can just have 2 witnesses. The witnesses, at least one of them cannot be a family member, though, or a spouse, a blood relative or a spouse. Okay. And then talking about advance directives in the context of hospice, a DNR is not a requirement to take advantage of hospice services. We do discuss the importance of advance directives with all of our patients, and we also offer training in having the conversation and getting the documents done. So my role as a community liaison, and you'll have a flyer about this on your table, or if you don't have one on your table, we have a booth outside with this on there. But I do something called a goals of care conversation. So for patients who are in their advanced stages of an illness and they're starting to have these dilemmas about the burdens of treatment becoming more burdensome and the benefits of treatment kind of falling off, they need to have a conversation. And sometimes it's hard to do that. They need to have a conversation and involve their family. And so I do this, oftentimes I'll spend an hour to 2 hours, sometimes longer, with the patient and family, and we'll just talk through how the disease has progressed, what their fears and concerns are, what quality of life looks like in their eyes, what's really most important to them as their disease progresses in their future decisions that are coming up. So we'll have a really in-depth conversation. And a lot of times patients want to do this, but they're afraid to bring it up to the family, or family members are seeing this and they want to bring it up, but they're also afraid to bring it up, or they just find it's difficult to have the conversation. So it helps sometimes to have a mediator, and that's the role that I play. This is a free service that we offer at Vitas Healthcare for anybody who's facing advanced illness. So it not necessarily only Parkinson's, any advanced illness. And feel free, our booth out there, she has a stack of my cards. If anybody is interested in that, please feel free to contact me. And I also do training sessions, like workshops, where we bring the actual documents and help people get them completed. Okay. So as people age, they need to be, well, and this says as people age. I kind of disagree with that. I'm going to say as people are facing chronic illness or serious illness, and as they age, right, both. It should be, you should be giving consideration to your treatment wishes. It's good to plan ahead, to be proactive, to empower yourself with knowledge about your particular illness and what kind of decisions you might be facing in the future. And what happens when people don't think ahead and talk about it and plan for it is what happens is crisis moments where people have to make decisions, and it's a lot of suffering and pain and trauma for the caregivers. So it's really important to relieve your loved ones of that burden by thinking ahead, planning ahead, talking about it. And we talked about there's a large discrepancy, right, between the wishes of dying patients and their actual experience at the end of life. We want to close that gap. And the way we do that is by having great conversations and not just one time. It's good to have repeat conversations. One of the things that we do in the goals of care discussion is ask people to think about someone you know, someone that was close to you who passed away, and what went well and what did not go so well. And when you look at those experiences, what would you have wanted if that were you, or if that, were someone close to you? So by watching other people's experiences, that can inform and help us to come and evaluate our values and our wishes for ourselves. So it's important not to put our heads in the sand and avoid this kind of thinking and talking. The clinician and the patient conversation, often clinicians, like I said, they're maybe not comfortable or they don't have a lot of time. It's important for patients and families to ask questions and ask, what is my prognosis? What do I have to face down the road? Help me understand this illness and where I'm at in this illness. If you can ask those questions, that will help your physician and let them know, I want you to be honest with me and how much you want to know. And then that will break down the barrier of them not sharing information with you. And let them know this is when it gets to this point, when this is what my quality of life looks like, whatever that is for you, let them know. At that point, I want to switch goals. I want to stop being aggressive, and I want to start focusing on quality of life and comfort measures. You know what that line in the sand is for you, or you hopefully will identify that and then be in communication. This is what I need to have my life have meaning and be quality. So don't just look to them to start that discussion. You start that discussion. All right, so I don't know how I'm doing on time. Oh, good. Okay, I have a closing thought for you. I have an advance directive, not because I have a serious illness, but because I have a family. And so that means take the burden off of your family by having your goals, values, and wishes identified and written down and discussed, so that when the time comes that your family has to make hard choices for you, they know what you would want, and it takes the burden off of them. All right. Anybody have any questions? Yes. Okay. Right. Right. Yep. That's a really great question. So his question is about CPR in the context of calling 911. And what you said is very right and spot on. If you call 911, they are obligated to do everything they can to save your life. So when you get to the point where you need to be aware of how your disease is progressing. And when you are getting into the advanced stages, it becomes more important to have a plan in place. And that's where hospice really helps, because if you're in the middle of a exacerbation, you're having a difficult time breathing, you're feeling panicked, your family's feeling panicked, instead of calling 911, you would call hospice. And hospice would come, because hospice is about relieving pain and symptoms, allowing a natural death, not doing anything to facilitate death, just allowing it to happen naturally, but making it as calm and peaceful and pain-free as possible. So they would be implementing medical treatment to relieve symptoms like shortness of breath, for example, instead of doing aggressive treatment like breathing tube and CPR and things like that. But the main thing is, if you know that you're facing that if you're getting into that advanced illness stage, maybe not having a policy not to call 911. would be the thing to do. I mean, you can have the document there to say, your family can say, look, we don't want CPR, but then why are we calling 911? Because that's what they're trained to do. Hospice. So if you're at that point, hospice. If you're at that point, yeah. So when you get into the advanced, so here I have for you guys, I looked up what it looks like in the advanced stages of Parkinson's, okay? And I'm just going to read this off to you. Drug treatment becomes less effective or increasingly complex. There's a reduced independence, more activities of daily living, which is like feeding, bathing, toileting, all of those things you need assistance with. There's a lot more of the off periods, so the disease is less well controlled, more mobility problems, more falls, increased psychiatric depression, anxiety, hallucinations, things like this. More frailty, extreme weight loss, shortness of breath. So more rapid disease progression, more bedbound, unintelligible speech, difficulty with food, needing a pureed diet. These are some signs, right? Other things, difficulty with, excessive weight loss, dehydration, and more recurrent infections like aspiration pneumonia, sepsis, recurrent pressure ulcers, things like this. When you start to see more and more of these signs, that's when you need to be reaching out to a hospice organization. And it's a free consultation. You don't have, it's just it can be an information-only visit. Or if you're not sure you're even there, you can start with a goals of care conversation. And that can help to educate you about where you are and what you're facing and help you talk through that. But the main thing is not to wait until it's very late to take advantage of hospice. I also found something here where they were comparing ALS patients with Parkinson's patients, and they said in ALS, 64% of ALS patients enrolled in hospice for at least a median of 8 weeks. But in Parkinson's, only 56% enrolled and only for 3 weeks. So people are waiting too long. It's better to err on the side of caution and check into it many, many months before you think you need it than to wait until late, because hospice is going to be able to maintain your quality of life, work with your goals, and help you to live the highest quality of life according to your vision for that at the end of life, and avoid highly aggressive treatment.
Is hospice likely to be set up in such a way that they can respond to an emergency?
Yes.
Maybe I broke my leg or something.
Right. So.
I need help getting to care. I'm not going to die.
Right. 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 So he's asking, what if he's on hospice and something happens like a broken leg? What happens then? So yes, you would still go to the hospital and you would still be treated for that if that's what you would wish. It's not going to be that hospice would say, oh, you're on hospice, so nothing else, no other treatment. No, that's not the case at all. And hospice is available 24/7. We have a nurse who answers the phone 24/7. We have nurses who will come out any time of day or night. So if you need someone, you call, we will come. Absolutely.
That's helpful because I was rejected from my mother's living will, and she was in the hospital when she had a major stroke. The hospital is where you keep people alive no
Right.
matter what their living will says. And they didn't want her to die on their premises, so they sent her back to the
Right. Yep, that's what hospice is geared for, is to keep people, manage pain and symptoms at the end of life, keep people comfortable, highest quality of life for as long as possible, and allow a natural, peaceful death with dignity. Thank you. I'm sorry, I hear the music and the doors are opening, so I think that they're kicking us out. If you guys want, my card is at the VITAS table, and you have flyers on your tables as well. Thank you for your attention today.